Welcome to the deep dive. Okay, here's a statistic that really makes you pause. Fewer kids are getting end-stage renal disease, which is great news, right? But the healthcare costs, still incredibly high. We're talking over 194 million in Medicare dollars back in 2016 alone.
Yeah, it's quite the contrast.
So let's unpack this. In this deep dive, we're focusing on a really critical piece for these young patients, how we establish vascular access for hemodialysis. We'll be leaning heavily on insights from Rutherford's vascular surgery and endovascular therapy.
Right, and we've got some solid information here. It covers the current trends in treatment, why different access methods matter so much, and what's being done or tried to improve things for these children.
Exactly. And our mission today, really, is to understand this puzzle. Why are central venous catheters, CVCs, so often the first choice when kids start hemodialysis, especially when the guidelines, the recommendations, point towards something else for the long run?
That's the core question.
Okay, so let's start with the big picture. Pediatric ESRD. It's actually pretty striking that between 2004 and 2016, the incidence, the number of new cases, dropped by over 20%.
It did, yeah, 21.1% decrease.
Okay.
Went from about 17.5 down to 13.8 per million kids. It's a significant progress.
But like we said up front, the cost hasn't dropped in the same way.
No, and that probably points to, well, maybe the complexity of care or perhaps the costs associated with managing complications from things like CVCs, infections, replacements that can add up and sort of cancel out savings from fewer patients.
That makes sense. And it's important to remember how kids start treatment. Hemodialysis, or HD, is the most common initial step, right? Over half in 2016.
Correct. 51.2% started with HD, even though preemptive transplants and peritoneal dialysis, PD, are options too.
Okay, now here's where it gets really interesting. The National Kidney Foundation, NKF, has these KDOQI guidelines, pretty clear recommendations.
Very clear. They say for kids and teens 0 to 19 years old, over 20 kilos, who aren't expected to get a transplant within a year, the preferred access should be a permanent arteriovenous fistula, an AVF.
A fistula. But that's not what usually happens.
That's the disconnect. These guidelines have been out there, and many kids starting HD actually meet these criteria. But the reality, the vast majority overwhelmingly start dialysis using a CVC.
So why? Why this gap? Before we totally dive into that, what about the efforts to change this? There was the Fistula-First initiative.
Yeah, the Fistula-First Breakthrough Initiative, FFBI, started back in 2003. That was for everyone, adults included. And it worked pretty well. They aimed for 40% AVF placement, but by 2011, they'd hit 60%.
Okay, so progress there.
But then they realized pediatrics was, lagging behind. So in 2005, the International Pediatric Fistula-First Initiative, the IPFFI, was launched, specifically for kids. The goal was really about raising awareness among pediatric nephrologists, surgeons, dialysis teams, everyone involved.
And there's solid reasoning behind this push for fistulas, isn't there? The source material links more fistulas to fewer bloodstream infections.
Absolutely. The evidence is pretty strong. Fewer infections means better outcomes, fewer hospital stays. It's a critical piece, especially for kids dealing with chronic illness. Avoiding infections is just paramount.
Right. Let's get a better handle on who these pediatric ESRD patients are. We know incidence is down overall, but what else? The numbers peaked around 2003, apparently, and have kind of leveled off since.
Yeah, plateaued somewhat. In 2016, it was just under 1,400 new cases, ages 0 to 21, which, sounds like a lot. But compare that to adults. Over 123,000 new cases that same year. Puts it in perspective.
Definitely. And the total number living with ESRD, the prevalence?
Just over 9,700 kids in 2016. And looking at how they're treated initially, HD is most common first, like you said, but kids get preemptive transplants way more often than adults.
Oh, interesting.
Yeah, and even once they start dialysis, kids are more likely to get a transplant within the first few years compared to adults.
And long-term, what's the most common treatment modality?
Kidney transplant, by far. Almost 3/4 of pediatric ESRD patients have a functioning transplant. HD is second, then PD.
And the causes are different from adults, too, you mentioned.
Totally different. Forget diabetes and high blood pressure dominating like in adults. For kids, it's mainly congenital stuff, things they're born with and acquired disorders. Things like primary glomerular disease, congenital anomalies of the kidney and urinary tract, or CACUT. Those are the big ones.
Okay.
Then you also see cystic or hereditary diseases and secondary glomerular problems like from lupus or vasculitis.
Specific conditions like focal glomerulosclerosis, renal hypoplasia.
Yeah.
It's a really diverse group of causes. And the sources also mention racial disparities.
Yes, that's a really crucial point to highlight. African-American children have a higher percentage of kidney issues linked to systemic diseases, things like sickle cell, AIDS, or lupus nephritis. It definitely adds another layer to think about for treatment.
So, thinking about the impact, ESRD obviously takes a toll. Higher rates of illness and death compared to other kids, but thankfully the overall mortality rates are improving.
That's true. A positive trend. The one-year mortality rate did decrease between the late 2000s and the early 2010s. Still, the type of treatment matters a lot.
How so?
Well, mortality rates are higher for kids on HD and PD compared to those with a successful transplant.
The 5-year survival data really drives that home. 95% survival with a transplant versus 82% for HD or PD.
Exactly. Although, interestingly, the youngest kids, the 0 to 4 group, had slightly lower survival overall.
And the main causes of death?
Mostly cardiopulmonary issues, heart and lung problems, and infections, especially bacterial infections.
And these same issues, cardiopulmonary infections, are also the main reasons kids with ESRD end up hospitalized.
Yeah, they lead to a lot of hospital admissions. On average, quite high rates. And again, kids with transplants tend to have the lowest admission rates. It all circles back to the benefits of transplants, but also highlights why managing things like infections, potentially linked to access type, is so vital.
Which brings us right back to the challenges of choosing the right access, especially in kids.
It's definitely complex.
Yeah.
You've got the technical side, small kids, small vessels. That's a hurdle.
Right.
But also, the transplant timeline is different. Kids might get a transplant faster than adults, sometimes. So that plays into the decision about putting in a long-term fistula.
And you're relying on info from caregivers too, right? Plus the child's own age and maturity.
Absolutely. And the sources point out some real barriers to getting more fistulas done. Things like communication gaps between the kidney doctors, the surgeons, the dialysis nurses. Sometimes they're not all on the same page.
Lack of coordination.
Yeah, exactly. Or maybe not enough surgeons comfortable doing these procedures in kids. Or just not having standard ways to refer patients early enough. And if a fistula is placed but isn't working well, delays in getting that feedback loop going between the surgeon and the dialysis unit can be a problem.
And it's not just the medical stuff. There are psychosocial aspects.
Huge. Fear of needles is real for kids.
Oh.
How it looks, how it impacts playing sports or swimming. These are big deals for a child or teenager.
But interestingly, despite the needle fear, most kids who've had both actually prefer the fistula.
That's what the data suggests, yeah. Which is fascinating, right? It tells you something about the day-to-day reality of living with a CVC versus an AVF, maybe the freedom or fewer complications.
Still, over 80% start with a CVC, and that number hasn't really budged in a decade.
It's stubbornly high. It really shows how entrenched this practice is, despite the guidelines.
The ideal, according to KDOQI, is getting that fistula placed months before HD starts, which means early communication is critical. Referral around CKD stage 4.
That's the gold standard. Get the nephrologist and surgeon talking early, well before dialysis is imminent, gives the fistula time to mature, to be ready to use. Of course, predicting exactly when dialysis will be needed can be tricky in kids, but the principle of early planning holds.
Okay, let's focus on HD treatment and the access itself. We know getting good access is priority number 1. The big push for fistulas, the FFBI and IPFFI, came from worries about CVCs, specifically central vein stenosis and infections.
Right. Those are the two big CVC bogeymen, really. And if you look at the data, like from NEPRTCS back in 2011, it showed the vast majority, like 78% of kids on HD had catheters. Only about 12% had fistula.
Wow, only 12%.
Yeah. And disturbingly, over half of those catheters were in the subclavian vein, which we know is a major risk factor for that central vein stenosis, the narrowing.
And you mentioned many CVCs are considered permanent. Does that make people less likely to push for a fistula?
It might, yeah. If you have a tunneled catheter that can last for months, maybe the urgency feels less acute. But the trend data is worrying. CVC use at the start of HD actually went UP significantly from the early 90s to 2010. Over 90% by then.
So the initiatives maybe didn't impact initiation rates as much?
Not as much as hoped, at least initially. Though a more recent snapshot from 2017 showed maybe some progress in the prevalent population kids already on dialysis. About half, 51%, had an AVF or graft.
Okay, a bit better. And that was linked to age.
Strongly. Older kids were much more likely to have a fistula or a graft. And there were some racial differences too. Higher catheter use in white kids, higher AV graft use in African-American kids. And kids with glomerular disease were most likely to have surgical access.
Let's hone in on CVCs again. Prevalence at initiation is high, 78–83% since 2006. Hasn't changed much. Why stick with them?
Well, we touched on it, the technical difficulty of AVF in tiny kids, yeah. Anticipating a short time on dialysis before transplant, so that's not always predictable. And definitely avoiding the needling aspect.
But the downsides seem pretty significant. Shorter lifespan than fistulas.
Oh, definitely. Often less than a year, sometimes just months. Failure rates are high, infections a big one, 17–40%. Clotting, thrombosis, maybe a third fail that way. Sometimes they just get pulled out accidentally or kink.
And the big long-term worry is that central venous stenosis, especially with subclavian placement.
Exactly. Rates cited are anywhere from 25 to 50% after subclavian CVCs. KDOQI has a preferred order for veins. Right internal jugular first. Avoid subclavian if possible to try and minimize this.
Does having a catheter on one side mess up putting a fistula there later?
Interestingly, in kids, it seems like having an ipsilateral catheter same side doesn't really hurt the long-term success of a future fistula. That's different from what's often seen in adults.
What about actually placing CVCs in kids? Any special techniques?
Yeah. Placement often needs general anesthesia, especially for the tunneled, permanent ones. Kids just won't hold still enough otherwise.
Makes sense.
And catheter sizing is tricky. There's no perfect formula. Bigger catheters give better flow, obviously, but you're limited by the kid's vessel size. Smaller ones might mean longer dialysis times. There's a rough guide some use, like size in French equals age plus or minus 2, but it's just a starting point.
And getting the right shape.
Also a challenge. Pre-curved catheters usually only come in larger sizes. So for smaller kids, the surgeon often has to create the curve themselves during placement, which might need an extra little incision.
Okay, now let's switch gears fully to arteriovenous access, fistulas and grafts. The gold standard is the autogenous AVF using the patient's own veins. How well do these actually work in kids?
Well, the early reports, say from the 80s, 90s, they weren't super encouraging. Lower patency rates, more complications compared to adults. But more recent studies show much better results. There was one study of over 100 fistulas in kids, mean as age 14, that showed really quite good patency rates. At 2 years, primary patency was 83%, secondary 92%. Even at 4 years, it was 65% and 83%. So it could be done successfully.
And initiatives like IPFFI have helped.
Seems so. They've shown it's feasible to implement these programs. And some surgeons find using things like an operating microscope helps improve outcomes, especially with those tiny vessels.
So what are the key technical points for creating AVFs in children? It's not just a scaled-down adult procedure, is it?
Not quite.
Yeah.
The basic types are the same: radiocephalic at the wrist, brachiocephalic in the upper arm, basilic vein transposition. But the execution needs adjustment.
Like what?
Well, the pre-op assessment is crucial. History, especially any prior CVCs, physical exam, and definitely vein mapping. The surgeon really needs to look at that mapping themselves. And because kids' veins can clamp down so easily, vasospasm doing imaging during the surgery under anesthesia is often really helpful.
Ah, the vasospasm.
Yeah, it's intense in kids. You have to handle the vessels super gently. Maybe use a tourniquet instead of clamps. Magnification, like loupes, is pretty much standard. Some even use microsurgery techniques to try and reduce early failures.
And the actual connection. The anastomosis?
Usually an anti-side connection, connecting the end of the vein to the side of the artery, typically done with a fine running stitch.
What if the arm veins aren't great?
Then you might look at transpositions, like moving the basilic vein to a more usable position. That can be done in 1 or 2 stages. 2-stage seems to have good results for maturation and patency. And if the arms are really not an option, femoral fistulas in the leg can work too.
Okay, so let's try to wrap this all up. What are the main conclusions from this deep dive on pediatric access?
I think the big picture is, kids with ESRD actually have pretty good long-term survival prospects now. But getting them reliable hemodialysis access, that remains really challenging and, frankly, not very standardized across the board.
And despite all the evidence pointing to fistulas being better long-term.
Right. Despite the evidence showing AVFs have fewer complications, last longer. The reality is most kids still start HD with a CVC. And those CVCs, we know, come with more problems, more hospital time, shorter lifespan for the access itself.
And the IPFFI, the Pediatric Fistula Initiative, hasn't really moved the needle much on starting with fistulas.
Unfortunately, it seems the needle hasn't moved a whole lot in terms of initiation practices over the last decade or so. The barriers we talked about, communication, referrals, surgeon availability, maybe even just inertia, they're still very much in play.
So the takeaway seems to be, given that many of these kids might need dialysis again later in life, even after a transplant.
Exactly. They might outlive their transplant. So preserving those veins, avoiding CVCs and their complications like central stenosis should be a huge priority. CVCs really should be reserved for emergencies or maybe very short-term bridges to transplant if they already have one.
It really points to needing more education, doesn't it? Getting these IPFFI type materials out more widely.
Absolutely. To providers, but also to families, so they understand the options and the long-term implications. Standardizing referrals, really improving that communication between nephrology and surgery, and just being proactive about troubleshooting potential fistula issues. Those seem like the key steps.
So, summarizing this deep dive, the evidence clearly favors the arteriovenous fistula as the best long-term vascular access for kids on hemodialysis. Lower complications, better outcomes. Yet, CVCs remain the dominant first choice due to a whole mix of technical, logistical, and maybe even psychological factors.
And understanding all these sort of nuances is just critical. Whether you're a parent trying to make the best decision for your child, or you're a clinician working in this field, the access choice really impacts everything for these kids.
Which leaves us with a final thought for you, the listener. Given this stark difference in long-term health and outcomes depending on the access type, what systemic changes, what shifts in practice are genuinely needed to make Fistula-First the default reality for pediatric patients? How do we overcome those persistent barriers? That's a question that definitely needs ongoing focus and a real team effort. Thanks for joining us for this deep dive.